I wonder if I could start by asking you just to introduce yourself and describe your specialism within the role of a haematologist.
I qualified in medicine in 1970 from Glasgow. After house jobs, I became what was called an anticoagulant SHO, who had to do the anticoagulant clinics 4 days a week. And that was in the Royal Infirmary. And I wasn't quite sure whether I'd go into haematology at that point, but I became very attracted to it because there was a lab side and a clinical side. So I guess I was signed up in about 1974 and I went to America for a year, worked with Charles Huggins in the University of Chicago. He was the man who is credited with hormone dependence of cancer. He got a Nobel Prize for that. Anyway, there was a rat leukemia model, so I was taking thyroids out of hundreds of rats for a year. It was good fun. And then came back and became a consultant at the Royal Infirmary. Very interested in hematological malignancies, particularly leukemia. And we started transplantation, and the patients had their total body irradiation in the Western, and they had their transplant in the Royal. We developed and built a new transplant unit there, opened by Princess Diana. And we were doing allografts for most of Scotland, and we started an autograft program. And that was really it. And then in 1991, I moved to Cardiff. But I was always interested in acute leukemia, and that also evolved into acute myeloid leukemia. Unfortunately, the trials were growing, and for some reason unknown to me, I got involved in the trials and was asked to lead the trials in about 1988. And these trials have been really quite successful. It's been a very great credit to British Hematology, these trials. They're internationally recognised. They're the biggest trials in the world now. And I think they're doing some patients some good.
So it was from your early days as an SHO in the coagulation clinic that then basically led you on to become one of the doctors who set up the bone marrow transplant service for Scotland, and then led you on to become an internationally renowned researcher, an academic in the field of haematology. I just wondered, was there anything else before those days as an SHO in the anticoagulation clinic that had sparked an interest in haematology, or was it really just that first exposure?
I was interested in the fact that you could see patients and you could also be in the lab. That was really quite attractive. About that time in the 70s, you know, my consultants were not generally clinicians. They came up, many of them, through pathology labs, and they started to look after patients. And I think probably I was one of the first generation of SHOs registrars who did the clinical membership. And at that point, there was an issue about where clinical haematology, which wasn't really recognised because physicians with an interest did it, where malignant haematology would go. Would it go as part of medical or clinical oncology, or could the haematologist grab it? And that almost, you know, that decided the future of haematology in my view.
I wondered actually if you could talk a little bit more about how you feel the distribution of a haematologist's workload now is between the clinical and laboratory side compared to what it might have been even sort of 20 or 30 years ago, whether there's been a transition now from lab to clinical, or whether you feel there's now a balance that's been struck between the two, or whether you feel actually you're able to choose now much more than you were able to in the past between focusing on one or the other.
I think the justification in the old days for having a consultant haematologist was based on the lab volume. I think with clinically trained MRCP type trainees coming through to consultant post, they regard themselves as clinicians. But so it becomes a personal choice, because the lab for many people is really quite an attractive place to work, and they may not want to do clinics. So I think there's definitely room, and there's a requirement really for both. But I think it's predominantly a clinical specialty now, as I would see it.
Within your own role as somebody who's been involved in the myeloid side of things for a good number of years and has become internationally recognised there, and has overseen quite a number of large-scale clinical trials, particularly within the UK. I wonder whether you had any feelings that towards the increasing complexity of these trials, the number of newer agents coming through and the number of combinations of newer agents, and how that might actually go on to impact the design of future trials, and whether there might be any issues with the complexities of these trials.
Yeah, you're right on a very topical issue. Very difficult to design a purely academic trial nowadays because of the new agents. Now, the new agents, let's say 8 in acute myeloid leukemia in the last 2 years, half of them were approved without a randomized trial to support the data. So, there's an obvious need to do that. And most of them are probably not approved in the context that we would like to see them placed finally, like the IDH1/2 inhibitors, for example. You probably want to see them, what they can do in first-line treatment, possibly in addition to chemotherapy. They kind of make me feel a little bit about bringing in atra or arsenic. You want to just see what they can do first line. So very difficult to see how you can do a traditional trial, which probably takes up about 5 to 7 years if you talk about the design and the follow-up. And difficult to think of a trial now that will be topical in 7 years' time. That's a challenge. So I think what we're looking at now, it must be new trial design. Probably a core of chemotherapy, probably with add-on randomized bits of the novel parts, which can be over in a year's recruitment or something like that. But some of these mutations that are getting targeted are quite rare, so even a large group like the UK probably could not do that on their own. And that's another feature really of the last 20 years. The specialists in myeloma or CLL or AML or ALL around the world all know each other. So setting up collaborations of that nature is certainly not impossible now. I think it would have been pretty difficult for the previous generation of hematologists to do.
Obviously, you've been practicing haematology for a good number of years and have practiced all over the world. I was wondering if I could ask you, in the entirety of your career, could you describe for me what you would feel your greatest moment or moments have been in your career to date?
Well, for some reason I was invited to give the Ham Wasserman lecture at the American Society of Hematology, which is said to be to an individual who's given, a non-American, who's made a contribution. There's a few other British people have done it, but that probably is something to be fairly proud of. I think the other thing that's not my pride, but I think British Hematology needs to be proud of their activity in clinical trials in some diseases. And in AML, the highest recruiting, the highest proportion of patients in this country is higher than proportion of patients going into trial than any other country in the world. They've got the best survival than it matches anywhere in the world. The guys putting in 4 or 5 a year from the district general hospitals have the same output as the guys with 50 or 60 patients a year. That means a patient doesn't have to travel to a big centre to get equivalent of the best care. That's a big testament to British Hematology, not just the haematologists, but the infrastructure, the nurses, etc., which I think we're very lucky with as well.
In terms of the British Society of Haematology, can I ask what role do you think they play in the development of the UK haematology specialty?
Well, they do various things, obviously. I think the guidelines were very solid, and that was good for both people making up guidelines and these busy hematologists running around with lots of different things to look at. It's handy to come back to a guideline if you've got a situation, particularly if it doesn't arise that often. So that's very helpful. I think the annual meeting is good for trainee hematologists who want to present their work. It's a good starting point. Gets you into the way of doing it in a situation that you can move on beyond that from that. It's not a political organisation. It's a learned society, and it's sometimes difficult to keep that distinction. Maybe it's less necessary now, with manpower and all that sort of thing. So I think it's another networking organisation which is very useful to most haematologists.
What aspects of working in haematology over your career have you given you the greatest satisfaction?
I think the clinical work and interacting, going in to see a patient they're usually aware that if they see me, they know they're in trouble, but, they've got leukemia and they know this is bad. And it's a great privilege to go into the room with something to offer them. There's nothing quite like doing that. So that can be good, but you've got to really think how you present the information to them, and come up with analogies that I think are easy to understand. I mean, my family's had cancer, and sometimes you feel the communication is not in ways that make it easy for people to understand. It tends to be a wee bit highbrow. So I think that's very important, that you develop a good technique of taking the time and doing that, and making sure that your nurse, your clinical nurse specialist or whatever, is on the same wavelength. I mean, they're not going to ask me whether they can wear makeup and all that sort of thing. They've got to help them with that sort of thing, and they do, and that's very important as well.
What advice would you give to somebody who's considering a career in haematology?
I think it's a good idea to go and talk to the hematologist. If there's a registrar or two around, talk to them, but talk to the hematology consultants and get a wee bit of perspective on what it means. They may offer an opportunity to do a ward round or two, or a clinic or two, etc. Visit the labs, find out what goes on in the labs.
Just my last question, can I ask, what are your biggest hopes for haematology over the next 60 years?
Well, clearly we've got to put the survival curves and the malignancies up a good notch. Maybe the genetic abnormalities in coagulation can be dealt with in an ethical way in terms of genetic engineering of some sort. That would be helpful. Blood products probably could do with becoming artificial. Don't know if that's realistic. So there's plenty to do.
Professor Alan Burnett, thank you very much for coming and speak to me today. Very interesting to hear your insights on how you feel myeloid malignancies, particularly AML, might develop. Wish you all the best.
Thank you, and thank you for their time.